Proton pump inhibitors are the third highest selling drugs in the United States, generating almost $14 billion annually. First proton pump inhibitor, omeprazole, was introduced into the market in 1989. Soon after, Jean-Paul Guelmiche, a French leading gastroenterologist, by the way, my teacher, master, and finally friend of mine, wrote an article anticipating that this group of drugs, very, very clinically effective, would lead patients and physicians alike to addiction. And indeed, this is the case. So now we have more choice of proton pump inhibitors, and we know that profound acid secretion is obtained with the inhibition of the last step of action. And the target of action of proton pump inhibition is HK-ATPase, which is a very important and potent agent called proton pump. On the other hand, in the increase pH in the stomach, more of gastrin is released on the way of feedback relation. It's important for our lecture. These three clinical situations are absolutely appropriate, and the long time proton pump inhibitor care is justified. Gastroesophageal reflux disease, and especially its complications as Barrett's esophagus is, prophylaxis and treatment of mucosal injury caused by non-steroid anti-inflammatory drugs, and Zollinger-Ellison syndrome, especially when curative removal of tumor is not possible, then the administration of proton pump inhibitor indefinitely is necessary. Studies have found that up to 70% of PPI use is for unapproved indications. So we have question about safety of their administration and beneficial and harmful balance of such therapy. The evidence for PPI adverse events is limited by the absence of strong data from level 1 studies, such as randomized controlled trials, and is based mainly on the observational cohort studies and case control studies. Effects of long-term, over 12 months use of PPI are the result of hypergastrinemia and increased intragastric pH over 4, which is our target. So potential adverse effects of long-term use of PPI are reduced intestinal absorption of vitamins and minerals, increased risk of infections, kidney damage, dementia, gastrointestinal neoplasia, gastric carcinoid, gastric cancer, colon cancer. Let's start with these last questions. Fortunately, the answer of 3 questions are no. Hypergastrinemia may induce carcinoid risk, but in animals, in rats only, no in human. In human only enterochromaffin-like cells hyperplasia only was observed without any clinical consequences. hypergastreinemia, and gastric cancer. In the condition where the level of gastrin, which is very potent trophic hormone of gastrointestinal tract, may pose the question about gastric cancer, but almost 30 years of observation and research didn't didn't answer yes, no, but obligatory eradication H. pylori infection before long-term PPI treatment is necessary and must be done to avoid the development of atrophic gastritis. The relation between hypergastreinemia and colon cancer is not clearly clinically observed. Trophic effect of high gastrin levels on colon cancer cells was observed only in vitro, and all the data comes from observational studies without any clear clinical association. But we very often we can observe funding gland polyps, and quality of evidence from observational studies is consistent. The funding gland polyps are the effect of trophic action of high gastrin levels on gastrointestinal mucosa. They are the most common polyps in gastric, in stomach in general population, nearly 2%. But the development of dysplasia in those polyps is the very, very rare event. So there is no suggestions to follow up the presence of funding gland polyps endoscopically. What is interesting, funding gland polyps are present almost only exclusively in patients without H. pylori infection. Our aim, our target is to reach pH over 4. pH over 4 in the stomach has consequences: increased risk of gastrointestinal infection and reduced intestinal absorption. What about infections? Gastrointestinal and respiratory tract may be concerned. Reduced gastric acid secretion, which is a local defensive system against orally ingested pathogens induced by PPIs, may facilitate bacterial infection in the gastrointestinal tract and, very important, change intestinal microbiota. Increased bacterial colonization of the stomach may be the consequence of descending gastric colonization by descending oral and from pharynx bacteria of different species. But there is no evidence about increased carcinogens nitrosamine production in this situation. Increased probability of colonization during PPI therapy may be also the consequences of ascending colonization from distal to proximal intestine. And this is the case of small intestine bacterial overgrowth. Small intestinal bacterial overgrowth is very, very important in cirrhotic patients with ascites, because that creates increased risk of spontaneous peritonitis and may complicate up to 30% clinical course of those patients. There is also the increased risk of very simple infections caused by Salmonella or Campylobacter, but not Shigella, because it's acid resistance. There is also, let's come back for a moment to SIBO. You can see that patients using PPI therapy are diagnosed with SIBO in over 50% when compared with healthy control, 6% only. There is very important data, recent data, about index mortality and 90-day mortality in patients with pyogenic liver abscess and PPI intake. In comparison with no proton pump inhibitor treatment, the index mortality is higher, 30% versus 11 index mortality, and 38 versus 11 versus 17 for 90-day mortality in these patients. So, re-evaluation of indication before administrating PPI therapy in the patients with risk at risk of pyogenic liver abscess. In PPI user, there is also the association with increased risk of Clostridium difficile infection, particularly in cases of concomitant use with antibiotic therapy. This combination, first of all, may result in dysbiosis, which is very important, but also in the condition of decreased acid presence. Spores of Clostridium difficile have more possibilities to survive and proliferation. So, two meta-analyses show that odds ratio is high for CDI infection in this composition of therapy. PPI use increases the risk of Clostridium difficile infection also depending on dose. And we can see that odds ratio is 2.36 on PPI twice daily. So dose depending, not only time depending, but also dose depending. There are, of course, many risk factors despite of duration of treatment and dose of treatment, which are indicated here. Advanced age, immunodeficiency, undergoing chemotherapy, and exposure to infected subject increases the risk of CDI infection. What about pneumonia? Pneumonia, if you want to explain plausible underlying biological mechanism, is the consequence of potential microaspiration of translocation into the lung from upper gastrointestinal tract of bacteria. But there is no consensus about this situation. There is no precise answer for the question if is there increased risk of pneumonia on PPI. The big meta-analysis of 26 studies shows that odds ratio for onset of pneumonia, community-acquired pneumonia, is 1.49 and is rising during first month of therapy until 2.1. And odds ratio of hospitalization is also 1.61. So, but the other results doesn't confirm this situation, and there is no consensus, epidemiological consensus about pneumonia on PPI. But be careful during first month of administration of PPI. Now, the problem of PPI and intestinal absorption of vitamins and mineral. Iron, vitamin B12, calcium, and magnesium are concerned. About iron, there is small retrospective cohort study with very confusing data, and in general we can see that in patient with normal stock of iron in the organism, this problem doesn't exist, but there are strong data in chemochromatosis. In patients with hemochromatosis have, when they are on PPI therapy, significantly reduced iron absorption, and even they have decreased number of phlebotomy per year. So this effect is very positive. Vitamin B12. Several studies were conducted, most of which reported 2 to 4-fold increased risk of B12 deficiency associated with long-term PPI therapy. This is the case especially of chronic use, 2 years and over, malnutrition, younger women, elderly, and Zollinger-Ellison patients, and Zollinger-Ellison syndrome patients. In 10% of patients, there is significant decrease of the vitamin B12 level, and almost 1/3 has subclinic deficit of vitamin B12. All those situations cause hyperhomocysteinemia and increased risk of cardiovascular disease. Calcium absorption in the condition of profound acid suppression is also altered. But water-soluble calcium salts nor calcium from milk or cheese are not concerned. The effects of PPI on calcium metabolism have been correlated to a higher incidence of bone fractures. So, supplementation is necessary. And supplementation of calcium should be taken with slightly acidic meals or preparation of calcium citrate to avoid calcium diminution in serum. Mechanism between long-term PPI use and bone fractures are complex and multifactorial, and PPI's long-term use results in hypergastrinemia, diminished absorption of calcium, and diminished absorption of vitamin B12. Hypergastrinemia causes parathyroid hyperplasia and parathormones augmented release, which provokes osteoresorption. Diminished absorption of calcium and hypocalcemia also increase parathormones release. And decreased absorption of vitamin B12 causes diminished level of homocysteine and diminished osteoblast activity. And those are the causes of this complex event. There are, of course, additional risk factors for bone fracture during long-term PPI therapy. They are kidney disease, corticosteroids use, arthritis, diabetes, alcohol abuse, and malnutrition. Almost 12 years ago, there were first cases of hypomagnesemia during PPI cure was described. And then, after then, during 5 years, there were reported other cases of this situation. So, Food and Drugs Administration released a warning that low magnesium levels can be associated with long-term use of PPIs. The clinical manifestations of hypomagnesemia are very serious, from gastrointestinal motor dysfunction, tremor, paresthesia, seizures, tetany, ataxia, cardiac arrhythmia, delirium or confusion, and withdrawal of PPI is necessary in those situations. As you can see, we can try to explain all those situations. For vitamin B12, malabsorption is the consequences of the fact that this is protein-bound vitamin, and it needs in the stomach the presence of acid and pepsin to be liberated and to be better absorbed after. Hypomagnesemia, the cause is poorly defined. Gastrointestinal malabsorption or renal wasting, risk of bone fracture, reduced calcium absorption in proximal jejunum as a consequence of hypochlorhydria. And now, let's go to the problem of renal disease. First cases of acute interstitial nephritis was described almost 26 years ago. And this situation is observed more and more frequently. Some cases can develop chronic kidney disease, and there are many convicting results. Among other, this is the result of a big meta-analysis, which says that chronic kidney disease is and acute kidney disease are the consequence of long time and high doses of PPI therapy. Plausible biological mechanism of renal failure is unclear. Deposits of PPI or their metabolites in the kidneys, tubulointerstitium, in the cells of proximal tubular seem to stimulate immune response and this pathological situation. But let's see, renal disease has strengths of association on modest level. And few words about dementia. The results comes from observational studies, and strength of association is uncertain, but the situation is very, very interesting. Several studies described association between PPIs and greater risk of developing dementia and Alzheimer's disease in older people. There are two big publications from last year. Excuse me, from last year's, and we can see from longitudinal cohort study and prospective cohort study that long-term PPI use may be responsible or associated with increased risk of dementia. The characteristic of patients published in both papers from the same researchers group was very similar with many comorbidities, with stroke, with polypragmacy, and they found the association between PPI use and dementia. The hypothesis is based on the animal model. PPI increase the production of amyloid beta in cerebral microglia in mice model, and PPI inhibit degradation of amyloid beta by lysosomal vacuolar ATPase. So, isoforms of amyloid beta are more stocked in the brain, and this is the model similar to Alzheimer's disease. But this is not the only risk factor for dementia. There are many other causes. Genetic factors with biomarkers as ApoE, drug interaction, very important in polymedicated elderly patients, warning on benzodiazepines, which are agonists of GABA-A receptors, and their level is augmented in serum by presence of PPI therapy. Vascular and blood-brain barrier dysfunction as consequences of hypertension or many drugs. Low and two events we have mentioned above: low level of vitamin B12 and hypomagnesemia. And we have the result of the last study from the last month of past year, PPI and risk for dementia in the study of Goldstein. Observational longitudinal study showed that continuous, always or never, PPI use decreases risk of decline in cognitive function and decreases risk of conversion to dementia due to Alzheimer's disease. So the results are very different when compared with previous publications. Obviously, prospective randomized studies are needed to explain this problem, because for the moment there is no consensus about it. So how to manage to reduce adverse effects of PPI? PPI prescription must be tailored using an individualized approach that limits use to robust indication to use minimal effective dose. Eradication of H. pylori infection should be done before long-term PPI therapy. Intake of daily dose of calcium should be increased in patients at risk. The best calcium citrate. Monitoring of the level of vitamin B12, especially in elderly persons. Monitoring of level of magnesium. Temporary PPI withdrawal during antibiotic therapy. Adults over 65 years are more vulnerable to adverse effects of PPI's long-term use because of higher prevalence of chronic diseases and polypragmacy. In most cases, based on evidence-based medicine, long-term use of PPIs is not necessary. Follow-up and re-evaluation of indication for this therapy are needed. The dose of long-term PPIs should be periodically re-evaluated so that the lowest effective PPI dose can be prescribed to manage the condition. Overall, PPIs are irreplaceable drugs in the management of acid-related diseases, but they are not without risk of adverse events. Adhering with evidence-based guidelines represents the only rational approach to effective and safe PPI therapy. Sometimes we need additional supportive medication in acid-related disease, especially in GERD, and we can use prokinetic drugs. Proteinalytic drugs available in Poland are metoclopramide, itoprid, procaloprid, and STW5. Itoprid, among them, has double mechanism of action on dopamine D2 receptor antagonist and inhibition of acetylcholinesterase, only peripheral action, and without the drug-drug interaction, good tolerance, and effective action. Looking forward, best future. Thank you very much for your kind and patient attention.